So, Assalamu alaikum, good morning, and thank you to Dr. Atif and the rest of the team for the invitation. It's an honor to present here today. What I'm going to do today is I'm going to go through in the next 20 minutes about some of the common etiologies affecting the brain in terms of the infections, and also go through some of the common imaging findings, okay? Thank you. Right. So basically, despite the strong blood-brain barrier, we still got almost everything which can infect the brain. As you can see the list, so any pathogen can get into the brain and cause infection. So there are much more common agents like, common bacteria, as we know, like Haemophilus, Strep, and Neisseria. But then there are lots of atypical agents also. Now, there are certain groups which also need mentioning: the opportunistic infections and also congenital and neonatal infections. So we'll go through all that, but I'll focus on the common cases so that we can learn some specific things today. So any of this can happen, that how the infection can get into the brain. It could be hematogenous, it could be local dissemination, we all know, through sinusitis or mastocytitis, or it could be through the nerves, especially the viruses, or it could be post-operative infections. So just to go through some of the anatomy here, there are several layers we can see for the protection of the brain. So from bone down to the dura mater, which is a 2-layer thick fibroblast and collagen layer which protects the brain. And underneath that, we have arachnoid matter, and then subsequently something covering the brain is the pia mater. So these layers define the spaces of the brain where the infection can localize and subsequently can spread into the brain also. So here's a schematic also showing us that how different compartments of infection can be shown. So you can see epidural abscess outside the dura, and if you come down, then it's the subdural abscess or infection. Then subsequently, it travels into the subarachnoid space, where we get the leptomeningitis, okay? And then if the infection travels further into the brain, then it can cause focal cerebritis or abscess formation and other sequelae. So for the next 5 minutes, I'm going to go through some of the cases. I want you to, especially the juniors, write on your mobile or piece of paper with the key diagnosis and some of the 2 or 3 differentials, so that you can check your knowledge at the end of the talk, that what you have learned, okay? So this is the first case. I'm not going to tell anything, but you can just see axial T2, and then we have ADC and a post-contrast axial T1. So try to write down some of the diagnoses you have. That way you'll really learn from it. This is the second case. And in all these cases, the clinical scenario is very similar: altered mental status, seizures, low-grade fever, or unwell patient, okay? So we have T2 axial, and then T1 axial post-contrast, and we have spectroscopy, okay? So we go to the next case. And we have T2 axial and 2 post-contrast axial T1 fat SAT sequences. It's another case, case 4, flare, then T2 axial, then we have pre-contrast T1 fat SAT, and then finally post-contrast T1 fat SAT. Case 5, flare sequences, and then a post-contrast T1 weighted image. Case 6, pediatric case, ultrasound of the neonate, and then a postnatal MRI scan, T2 axial. Case 7, T2 images, and then T1 pre-contrast and post-contrast T1 weighted images. Case 8, T2 axial and T1 axial post-contrast. Case 9, CT scan, non-contrast scan, and then axial T2. Case 10, getting to a little bit more difficulties. T2 axial and flare and post-contrast T1. Case 11, T2 images, immunocompromised patient. Case 12, final case. Right, so we've gone through cases. Now we're going to check that what we know and what we're going to learn about this, okay? And we'll touch on these each. Okay, so this is the first case. And as you can see that this shows a well-defined mass with extensive surrounding edema. And we've got, central restricted diffusion, and we have peripheral post-contrast enhancement. And there's a clue here where the infection is arising. Has anybody guessed where the infection is coming from? This is coming from the skull base osteomyelitis, as you can see around the right orbit. That's one of the ways, and we need to be vigilant to look for these findings when we look at these cases. So this is a very important case also. This is similar to the last one. As you can see, there's a thick wall lesion, and we've got extensive surrounding edema. A post-contrast enhancement is in the periphery. Now, this is the finding which we normally think is like in a high-grade glioma, that, if you see one lesion and next to it, you see another lesion, thick-walled, irregular, you start thinking about a high-grade glioma here. But when we did the spectroscopy, this is where you would actually, recommend, if you don't have spectroscopy, to utilize this. So this is what you can see here is that classical findings of cerebral abscess. So for me, the learning point was that I was thinking lipid lactate peaks. So you can see lipid lactate peak at 1.25 around that, right? But on top of that, the other more specific are the amino acids and also acetate and succinate. And you also see complete dropout of the Na, and choline and creatine are also reduced. So this is classical spectroscopy of cerebral abscess. You need to remember that. If it was a glioma, you would have seen what? Choline peak, okay? And, unless there was any necrosis, you wouldn't see lipid or lactate peaks, okay? So we talk about cerebral abscesses, okay? As you can see, what we have is lots of differentials, ring-enhancing lesions. Like a cavitating lung mass, you have to remember all that. Then you have to narrow down that what you think. So I'll just touch on a couple of things. High-grade glioma, I've touched already. Tumor-effective necrosis, we know that we see incomplete ring of enhancement as a differentiation to the abscess. Metastasis, you know that it will be peripheral enhancement and a restriction in the ring of the lesion rather than in the center of the lesion. And there are others also which you need to think about, and we can discuss in the discussion time if you want any specific questions related to that how we differentiate. So these are the utilizations when you deal with a ring enhancing lesion. You can use DWI. As we all know that, we have lots of centers, 0.3 Tesla scanner is done, suboptimal scans, they're labeled either abscess or glioma, suboptimal practice. And, and then, we have to order either DWI and spectroscopy depending on the need, what we see. And perfusion scan you can use because perfusion will be more in tumors or in metastasis, okay? Particularly in a glioma, perfusion will be more. Okay, so case 3. I'm sure everybody got that. This is a leptomeningitis, okay, leptomeningeal disease, typical pattern, and we have some pattern of basal meningitis as well. So any organism can cause that, okay? TB, bacteria, less likely viruses, but 3 are TB, bacteria, and fungi can do that. But basal meningitis is most often caused by TB. But there are other differentials we'll discuss, like neuropsychosis and the inflammatory conditions, okay? But when you see this sort of pattern, if you don't see any nodules, okay, in the leptomeninges, then you think about pyogenic leptomeningitis. If you start seeing nodules, think about TB or carcinomatous leptomeningitis in the right clinical setting, okay? So this is what we have. As you can see, the differentials here. So I'm sure you all got those differentials, and I've touched on those. So here is the important bit, right? Whenever we report as radiologists, we need to think about the possible sequelae or complications of any disease we see. Okay, so I've listed all that. But importantly, when you see ventriculitis, you see enhancing lining of the ependema or septations or abscesses within the ventricular space. Okay, and the other bit is also, especially with fungal infections, you see arthritis or vascular occlusions, you need to look for venous sinus thrombosis, you need to look for infarcts. So these are all complications of meningitis or intracranial infections. So case 4, very interesting one, endemic to our place. I'm sure, again, you all got that. So there are various stages of tuberculoma, okay? Right? Depending on, where it is, if it's end stage, you will all see is a dark spot. And even on the CT, you will see some calcification. But this is a stage where this is actually a caseating, situation where this is causing some reaction and there's edema around it. And you see this typical thing here. What you see is, you see a low signal overall lesion. There is some internal high signal change on the MRI scan, which is suggesting that it is developing into liquefactor necrosis. So if it becomes bigger, it can develop into an abscess, okay? And then the key finding is also on the pre-contrast, you see a high hyperintense signal, which shows a typical thick wall enhancement, very typical feature, okay? So these are the features of tuberculoma we have discussed. But this is not the common presentation, okay? You have to remember basal meningitis, as I mentioned, is a common presentation. And these are the stages of the tuberculoma, as I mentioned, okay? The key is the caseating type, which will cause the typical features of tuberculomas, okay? That's the key here. Now, you do see target sign in neurocysticercosis, okay? But this is less common as compared to the cysticercosis. Important to remember that, okay? DDs we have discussed. So tuberculoma has all the DDs of cerebral abscesses, but it's a typical finding of very small lesions, okay? Case 5. How much time? Oh, okay, that's fine. Okay, so guesses, residents? Excellent. So what would you do when you see this sort of scan? You'll pick up the phone, okay? Because this is a high mortality and morbidity case. Patient can develop a fulminant necrotic encephalitis. And, this is typical finding where we have involvement of the limbic system, insular cortex, medial frontal lobes, okay? And the key is that it's generally asymmetrical, okay? And then there are other differentials we'll talk about. But look at this. We talked about leptomeningitis. Even the viral infection is causing leptomeningitis here. Can you see the basal meninges here? They're enhancing abnormally. And we also see the medial temporal lobe, which is showing some enhancement, okay? So some worrying things about this. So always remember that, and limbic system is involved, and the gold standard is the CSF PCR. But you don't have to do it to give them acyclovir. That's important to just to start when you suspect it, to protect the patient, okay? The DDs, okay, limbic encephalitis has similar. It can be asymmetrical or symmetrical as well. Same regions are involved, autoimmune process. And then we have status epilepticus. So how do you know that status epilepticus will differ from here, from this herpes? So there will be restricted diffusion, okay? And also with time, you will see that most often this will all completely resolve unless ischemic or metabolic insult has happened due to status epilepticus. Then the abnormality will not resolve. So follow-up scans will be very important. Recommend that. Gliomatosis cerebri, usually on the unilateral side, a lot more as compared to bilateral involvement, more extensive, more mass effect. And then you can employ the perfusion scans and the spectroscopy just to nail the diagnosis down, okay? So I thought it's important to mention at least one of the congenital infections, which is the most common congenital infection. Which one is this one? Cytomegalovirus, okay? And ultrasound shows the periventricular high signal, hyperechoic foci compatible with the calcifications. And then you see some typical features on the MRI scan. Although I deliberately did not show you a lot of calcifications, you would have got the diagnosis correctly, but this makes you think, if you just have the MRI scan, how would you approach it? So there are lots of features. We have brain atrophy, okay? We have brain atrophy, we have some hydrocephalus, we have polymicrogyria, and extensive white matter lesions, leukoencephalopathy. So all of that, and if you did the rest of the scan, you would also see some periventricular and some basal ganglia calcifications. There's some words about this. This most common cause of intrauterine infection is part of the TORC diseases. Okay, important to remember. But most often, when you see calcifications, most of the congenital and perinatal diseases will present with calcifications on scans. Okay, so these are the things I've mentioned already. The migration abnormalities you have to remember: the schizencephaly, lysencephaly, polymicrogyria. You know, as radiologists, we like to look at the associations. Okay, so case 7. Okay, pretty classical case. You see, what do you see first? The sinuses. In this case, T2 low signal abnormality, very typical of fungus. You don't have to have low signal abnormalities, but you know, this is quite typical, and you shouldn't miss that, because this will have implication on the patient management if you just call a bacterial meningitis. So what it's causing is it's breaking the bone, and it's coming into the brain parenchyma, causing focal cerebritis. All of this is called the cerebritis, all of that, okay? And there is a focal enhancement, and then, you know, this is leading to abscess formation. So this is the spectrum of the start of the disease, from outside to the inside, from the meninges to the cerebritis, to formation of encephalitis, and then the abscess formation, okay? So this is, which one is this? Very typical. I'm sure Atif, I will not ask Atif, but you know, so this is another fungus, okay, immunocompromised patient. Okay, we have gelatinous pseudocysts in the basal ganglia. We have leptomeningitis also, and we can get cryptococcus with this as well, okay? So fungal infections, we come to this topic, and these are most common opportunistic CNS infections. So I want you to remember this. When we're dealing with immunocompromised patients, in our setup, cancer patients or HIV AIDS patients, think about the fungal infections as a differential, okay? So aspergillosis, whenever we are dealing with aspergillosis, please remember that this is very notorious to cause infarcts, thromboses, and all that. So look for the sequelae of arthritis, and most importantly, mycotic aneurysms. I've seen a few of these, and you know, these can easily get overlooked, and patient can die from the rupture. So cryptococcus, we have mentioned already that it's in the immunocompromised setup, and these are the things which can cause meningitis and cocomas, and also typically is coming from the lungs, hematogenous spread, okay? So case 9, we'll move a little bit fast. So Aunt Mani, case, yeah? Yeah, neurocysticercosis. Luckily, we don't have this here. You know why we don't have this? Why don't we get here? Resident will answer. Exactly. Okay, we don't have this organism, Tinea solium, okay, tapeworm, all right? So luckily we don't have that, but you know, typical features, target sign, okay, it can be intraparenchymal, extraparenchymal, it can look like, you know, arachnoid cyst, but you have to look for the dot sign, and you can also see on the MR scan T2 low signal dot, okay? Right, so we've got 2 minutes, so we'll go through. I'm sure we'll get through. So these are the stages, okay? So the colloid vesicular form is the most important one, if you remember that, okay? This is where the parasite dies, and the brain starts causing reaction around it, okay? And then we get the edema and the enhancement and the turbid and a high intensity T1 lesion, okay? So this one, 2 signs I'm showing you here, the eccentric target sign and double ring sign. What is the diagnosis here? So basal ganglia predominance, and then, you know, you see the target sign here, eccentric and double ring sign, okay? So this is seen in toxoplasmosis. Again, immunocompromised patient, opportunistic infection, typical features, and then lots of other differentials because of basal ganglia. You have lymphomas, other infections, And we have ways to actually differentiate those. Okay, we can do MR perfusion or PET-CT or thallium SPECT to differentiate between lymphoma and these lesions. Because in immunocompromised patients, you can have an atypical lymphoma, which will just show the ring sign. Okay, so case 11, typical case, asymmetrical, extensive white matter disease in HIV, AIDS, or immunocompromised patients. Yeah. PML, excellent. So it has also a lot of differential, but remember it's asymmetrical, and the key differential is the multiple sclerosis. Okay. And how do we differentiate that? This is because of the JC virus. This is interesting pathophysiology, reactivation of JC virus. In fact, in the amazing, how things develop. Okay. So these are the classical features, but there's something called iris. Have you heard? Anybody has heard iris? Yeah. Immune reconstitution. Yeah, response, inflammatory response. But if that happens, you see the enhancement of this. Okay. Entity. Otherwise, you will not see the enhancement. Okay. And with MS, we have classical differentiating points. MS is more periventricular, more well-defined, more enhancing lesions if they are active. U fibers are involved in both cases. So last case, and then I'll finish. Okay, we saw a similar case very recently in our hospital. Yeah, this is, whenever you see something like this, think about metabolic disease, first of all. Uremia, hypoglycemia, carbon monoxide poisoning. But because this is infective talk, so this is because of CJD. Okay. Yeah. Basal ganglia and reverse hockey stick sign, or you have pulmonary sign. Okay. Two signs. Basal ganglia. Remember those. And it's the genetic testing. No, it's the biopsy, brain biopsy, the gold standard. So just some features here, and we'll just skip through quickly so we finish. So I didn't include this in my talk initially because obviously it needs another 20 minutes, but look at the whole long list. But all of this can be easily differential of many of the diseases which I have mentioned, okay? But I tried to highlight some of the key points so that we remember and try to differentiate, okay? So yeah, once again, so remember the context of the patient, okay? Have good history and also discuss with clinicians, and then think about the appropriate differentials. Don't get compromised on the imaging. If you don't have DWI and if you need one, ask for it. If you need spectroscopy, ask for a good quality spectroscopy, okay? And don't hesitate to reject scans if they're not of good quality. And then when you have everything, consult a colleague, neurologist, neuroradiologist, that if you're not getting to the point, okay? And we have other things as well, how we can deal with it, because we look at the labs, we look at the, other parameters of the patient. Some of the references, and thank you. Okay. Any questions, anything? Okay. Hope you enjoyed.